This seminar has also been endorsed for one TRCB CPD point. Polina is the Evaluation Director for the Knowledge Management and Mobilization Group at the University of Utah in the United States. He holds a PhD in Biomedical Informatics from the University of Utah and a Master of Public Health degree in Biostatistics from the University of North Carolina. And today she'll be presenting on her work on establishing an evaluation program for smart on FHIR apps at an academic medical center. I'll hand the time over to Polina now.
Thank you so much, Dawn, for the introduction. I'm excited to be here today at the Center for Digital Transformation of Health. And I'm going to talk today about our evaluation program. And I hope it will help you to better evaluate your own EHR-based intervention. Dawn just told me that in the hospitals in Melbourne, most hospitals have Epic installed. So you can start building on top of Epic and evaluate those interventions as well. Before I begin, I would like to give you two definitions because people get confused between these two sometimes. So in this lecture, I will use evaluation as measuring and exploring properties and impact of a system, and could be any system, doesn't have to be health technology. While health technology assessment is a discipline within evaluation field, which allows to evaluate a health technology. So with this out of the way, today I'm going to talk about three things. First, I will tell you about establishing an evaluation program here at the University of Utah. And then I will show you a project with individual evaluation, which we did for one of our first apps, the Billy app, neonatal bilirubin management app. And finally, I will share with you another projects which we are currently in the middle of. This project is about improving our evaluation program so that we can bring insights from different fields, such as user experience research and health technology assessment and implementation sites. Before we begin, I would like to tell you a little bit about myself. I have 10 years of experience in health technology assessment. I started when I was doing my Master's of Public Health at UNC, which is one of the best schools of public health in the United States. So I did evaluation of public health intervention and pharmaceuticals and supplements. And then I moved to Utah to start my PhD, where I did evaluation of health services. And then about 5 years ago, I switched to evaluation of electronic health record or EHR-based interventions. And finally, 2 years ago, I started to work on evaluation of smart on FHIR apps. I was fortunate to work with Division of General Internal Medicine. We did a lot of evaluation of the EHR-based interventions which doctors developed. And these 6 were recently published in different areas, such as cellulitis care, sepsis, pneumonia, and so on. So why do I care so much about evaluation? I believe that there is insufficient evaluation of health IT. Health IT has historically been poorly evaluated. Even though there are a lot of evaluation frameworks and guidelines, people still don't really do it. A lot of health IT interventions introduces quality improvement, and without institutional review board for research, without any randomization and really any evidence that they are working. People just have an assumption that it will work and it's a great idea. And that's that sometimes is the end of the evaluation. And what it could lead to, right? It could lead to a lot of funding being invested into developing something that is never used. Or even worse, when physicians are forced to use information technology which they don't like and would rather not use, which can lead to alert fatigue. That's what happened in the United States with a lot of alerts firing and people just being tired of them. And clinician burnout when they don't even want to go to work because electronic health records are so tedious, and medical errors and low quality of care. So it is important to evaluate things. And there was a new development. I think I see Graham Grimm there. I'm super excited to meet you in person. So there was interoperability standards developed. And on one side, it's exciting because now healthcare system can exchange information, and FHIR standard could be used to specify APIs so that data could be exchanged between an electronic health record and an app in a standard form. And those apps could be distributed to the whole country later. The same app could work with different electronic health record systems. And smart standards allow us to integrate this app within HR so that clinicians doesn't need to do authorization twice. They might not even know that they are inside the app. But this nice development in interoperability standards is also a little bit scary because the barrier for entering the development field has lowered, and now it's easier to make these apps, which means that a lot of groups will spring up both within academic medical centers and third-party vendors who will make their own apps. And as a society, we should hope that these apps are efficient and safe. And for example, I was a reviewer for AMHL7 Showcase this year, and out of 5 submissions which I got to review, only 1 had really good evaluation. And the rest are like, well, we are just starting, so why would we do evaluation right away? We need to do it a little bit later. And for that, I will say that no, evaluation is a strategic investment. And here's a quote from Software Engineering Google Book: "Finding problems early in the development workflow usually reduces cost." And here's a graph which shows how the longer you wait, the more expensive every error would be. And this goes to both testing and evaluation. And I really like this quote called Broxton Law, which talks about evaluation. It's always too early until, unfortunately, it is suddenly too late. And also, even if developers still don't want to do evaluation, stakeholders now demand it. In America, FDA actually now requires more evaluation for health IT. And everyone, health products maker to regulators to clinicians, asks us for evaluation results. Okay, so that was a short intro about why I think evaluation is so important. And the main talk will have 3 parts. First, I will talk about establishing an evaluation program and where it fits within our healthcare system. Then I will give you a very specific example of Billy app. And finally, I will talk about improving evaluation program. I guess I already said that. But let's start with part number 1, establishing an evaluation program. I work at the University of Utah Health. It's a system of 5 hospitals and 12 community clinics in the Mountain West. Here is where we are. And on the hospital side, we have CMIO division, which has 5 subdivisions, one of which is knowledge management and mobilization group. So we do different things. For example, we work on electronic clinical quality measurement. We also help with clinical decision support governance. But today I'm going to talk about this other side with Reimagine HR initiative. So the first part of the initiative focuses on development of smart on FHIR apps, and the second side focuses on evaluation. But we didn't always have an evaluation program. The Reimagine HR initiative was founded in 2016 and is directed by Dr. Kensaku Kawamoto. And in 2017, we had our first app called Billy app in clinical use. In 2018, team size doubled and they hired me and we started the evaluation program. And in 2019, we published a paper with evaluation of the Billy app. And now we have 9 apps in clinical use, which I think is actually one of the most effective programs in the United States so far, with so many apps in clinical use. So that's how an Reimagine HR initiative looks now. We have 10 core members who report to Ken, and we have over 50 collaborators and 10 products. And we are focusing on creating interoperable HR-based digital innovations, which means smart on FHIR app and some apps which use different standards, but still could be shared across electronic health records. So now, evaluation program. As you remember, it's nested within the Reimagine HR. It has only one core member, which would be me, but we have over 20 collaborators and over 10 different projects. I just showed you publications from 6 HR-based interventions, and we are working on evaluation of 5 smart and FHIR apps, which we have in clinical use from different areas, from neonatal bilirubin management to lung cancer screening and chronic disease management and medical calculators. And a very important contributor to our initiative is Dr. Charlene Beard. I don't know if many of you know her, but she had 30 years of experience in user experience research. So why did we need evaluation program? Because we needed executive buy-in. After a couple of years, the executive started to ask, well, what can you show for all the money? And we also need to prioritize resources. We are a tiny group with just 10 people, right? 10 core personnel. That means that we don't have enough resources for everything. And we needed to identify places where we needed to fix things first. And we also wanted to create usable and safe products to inform design and development and to make sure that they are safe. Here are different parts of evaluation. I'm showing people who usually do it on every slide. So you can see that it's a lot of people are contributing and there are a lot of things to do. Okay, now we are going into the first project, evaluation of the Billy app. It was led by 4 women. And the problem which we were trying to address is infant jaundice. Some babies are born with high concentration of bilirubin in their blood, or it develops over time. But especially for premature babies, it's very dangerous. For example, my nephew had jaundice and he and his mom had to be hospitalized. And the danger is the complications, because if it left untreated, babies can get brain damage for the rest of their life. Fortunately, bilirubin, high levels of bilirubin could be treated with phototherapy, because phototherapy destroys bilirubin in the bloodstream. But babies don't like phototherapy. They cry, parents get upset, and they get rashes and loose stools. So doctors have to decide, right, whether they are afraid of these very rare complications or whether they would go for these very common effects of phototherapy, which are negative. Fortunately, in America, we have Academy of Pediatrics, which published the guidelines. So this is what happens at 24 hours of life when babies are screened for their bilirubin level. If it's below the threshold, then nothing needs to happen. Babies could be discharged. If it's close to threshold, babies need a repeated bilirubin test. But if it's above threshold, then babies need to receive phototherapy within 4 hours, and then bilirubin test is repeated. But the hard part is that bilirubin thresholds, as the baby is growing, the bilirubin threshold keeps also changing. So it's not a line, it's a curve, which is hard to calculate. In summary, our goal was to improve neonatal bilirubin management and prevent neurotoxicity, and we created a smart and FHIR app to do just that. And we use user-centered design led by Charlene Beard, and it is integrated with Epic, which means that it gets all the data from Epic, and custom FHIR interfaces were developed as needed, because at that point, US core FHIR profiles didn't really have all that many elements, and time of birth was missing. So we had to develop our own interfaces in Epic, and then use those interfaces to get the data for the app. So let's see how the app looks. The blue part outside is Epic. The screenshot was taken in Epic, but the part inside is the Billy app. And you could see here this curve, the green threshold, and the blue line is bilirubin level in this baby. And you can see that it's slightly above the threshold. This is why baby received phototherapy. And then the bilirubin level went down. And here's the second part, where we pull all the data from Epic automatically. For example, we pulled direct COMPS results, which are important to determine the threshold, and albumin test, and gestational age. So this baby was born in term at 38 weeks or more, but clinicians might wonder, well, what would have happened if they were born at 37 weeks instead of 38? And they can click 37 weeks, and what you could see here is that the threshold changed. And now the situation looks much more dangerous, right? So maybe they did exactly that, and then that's why they prescribed phototherapy. And the app also gives advice what they should do. They should continue monitoring and predicts whether hyperbilirubinemia is likely to happen again, and pulls mother data as well, which was also hard because there was no interface to pull data for a relative. And our developers had to develop this additional interface. Now to the evaluation. We had several questions about the app. The first one was, did physician save time using Billy app? To measure that, I went to the nursery and measured how long it takes physicians to access this data while they're using traditional HR and while they're using Billy app. So when they were using traditional HR, they actually had to go outside of the HR to a website, enter all the data there. The website is called Billy Tool, and it took time, right? And it also takes cognitive effort because you have to remember these numbers while that you're transferring them from the HR. And then the website also didn't have a graphical interface, so they couldn't see the trends. And with Billy app, it took them only 35 seconds. So they saved 60% of time on this task. Next question we had was, did at-risk babies receive phototherapy? And it was actually much harder to figure out than you would think, because we didn't want all the babies to receive phototherapy, only the ones who needed it. And at first, everything makes sense when the baby's bilirubin was above threshold. And you can see here that the phototherapy increased from 74 to 84%. So that's good. But when we combined together all the babies who had results below the threshold, we saw that some of them also got phototherapy. Like, well, that's not right. And then we figured out what was going on. There were two groups, actually. Babies who had bilirubin well below threshold, and others who had two measurements, one below and another one much higher. So now with the graphical interface, physicians could see if the bilirubin level is about to cross the threshold. And in that situation, they decided to prescribe phototherapy preemptively. So those cases, which we call trending up, increased twice from 27 to 54%, which was a very interesting result, which shows that using graphical interface really changes clinical care. We were also wondering, did clinicians use the Billy app? And the use in the nursery was almost universal at 92%. But when we looked in outpatient clinics where the babies are brought, when they're discharged maybe on day 3 or 4, the use was not so high. And finally, we sent a survey to everyone who used the app in the past months. And the survey was System Usability Scale, which allows to measure how much people like the app, how easy it is to use. It goes from 0 to 100, and the industry average is 68, which is somewhere between okay and good. And our result was actually from 84 to 92, which corresponds to excellent and best imaginable. And here is a story from an outpatient clinic. Carol, one of the pediatricians, sent us this email, which was very nice. So they had this situation when a baby came into an outpatient clinic, and it was a COMS positive baby, which meant that they are more sensitive to bilirubin. And the results were high, and the family was waiting until later in the evening to receive the second test, because either they had to be hospitalized to go home and they wanted to go home. And in all that suspension, the result came way below the threshold. And then a physician actually turned the screen and showed it to the parents. And they were able to understand right away what was going on, and the whole room burst into cheers. Love this story. In summary, the app improved guideline compliance, saved time. The usage was almost universal and it was well received. Hope we will save some babies in the future. And the evaluation was published in a really good journal, JAMA Open, and we won 2019 AMHL7 showcase. But like, we could have patted ourselves on the back and just continued like that with other apps. But actually, when we thought about it, there were a lot of problems with our approach. And next I'm going to tell you what problems we found and how we are going to fix those problems. So let's get to project 2, improving evaluation program. Here's another example why our evaluation approach is not very good. You could see here on the x-axis dates and on the y-axis usage. And you can see that it goes up and down. So there are 2 apps. The red one is the Billy app in this summer, and the green one is Medical Calculators app. And Medical Calculators app used to be very popular, but now it wasn't used all that much anymore. And we wondered why. And finally, we looked in Epic and found out that for many people, it was going into rarely used place where it's really hard to find. So people pretty much just couldn't find our app and couldn't use it. So we got approval and returned it in the main menu, and the usage went up. But it took us like 2 months to even notice that this was happening, right? Because we are not doing evaluation as well as we could. And we're not doing really good evaluation because we have limited resources and a small team. And then we asked ourselves, well, how can we improve our evaluation program? And how can we bring insights from all these other disciplines to make our evaluation truly holistic? Here are 4 specific challenges which we found. First, our approach was not really systematic and was narrow scoped when we were focusing mainly on the evaluation later on, and there were some blind spots. And it also didn't incorporate any theoretical models. And we didn't really decide in advance what outcomes we are going to measure. For example, remember I told you about measuring whether phototherapy was given 4 hours after the positive bilirubin test. All that I figured out later on. No one really defined this at the design stage, even though it would be a natural place to think about the outcomes. And we also didn't use any implementation strategies. Our implementation strategy was the word of mouth, which means that we turn it on and hope that people will use it and tell each other. And it worked well in the nursery because everyone is together in the nursery. But in the outpatient clinics, there were some outpatient clinics, well, no one told them and they didn't know. Even people who were supposed to teach students, they still didn't know. And finally, our approach is not scalable. It took us a year to do the first evaluation, and we have tens of interventions. And so currently, right, we can't do it unless we clone some people. So we decided to focus on 4 approaches to minimize blind spots by combining insights from 4 disciplines, to finally start using theoretical models, to improve links between the phases, and to reuse pragmatic methods to improve scalability. So we decided to make a list of pragmatic methods so that we can use them wherever appropriate. Okay, so first let's talk about minimizing blind spots. There are 4 different disciplines which we think are very relevant to HR-based interventions. First one is software development, and software developers are more focused on actually developing the software and testing it, but not as much in like talking to people. Implementation science is another discipline which focuses on getting the adoption up. So they assume that you already have a great intervention, and now they can give you a lot of strategies to actually bring the usage up. But they're not very concerned with development. They assume that you already have something that was tested and has proven value. Then there is also health technology assessment. That's what I do. And this is assessing properties and impact, but without worrying too much about adoption or development. And finally, user experience researchers focusing on users. They wonder what a user needs and motivations, and right, not so much even how we can motivate them. But at the end, they want to know if it's easy for the users to do their job well, to do their tasks, and if the intervention fits into user workflow. And surprisingly, people from these 4 disciplines don't talk to each other very much. And I will explain why soon. And obviously, we are all working to make healthcare better. So the 5th group of people would be clinicians. So what questions can people ask themselves when they're software developers? They would be curious, what design should we use, and how to design and develop the solution. Implementation scientists want to increase adoption, so they're thinking about implementation strategies. Health technology assessment researchers wonder whether we delivered value. And finally, users are wondering what are the needs. And since it's different questions which these disciplines are trying to answer, they developed different theoretical framework. So now we wanted to use different theoretical frameworks and decided to review what was out there. And we found that indeed, every field has a lot of frameworks. In total, there are over 400 frameworks, which is hard to comprehend, but here are some examples. Software developers think in terms of software development lifecycle, which consists of pretty different things than implementation frameworks, which think about factors which will influence adoption, such as context or leadership. Value assessment frameworks obviously think about value and how much it will cost to do this intervention and what would be the return on investment. And user experience frameworks are centered about why people would use one intervention, not another. Here are examples of models, and I'm only going to talk about the top one, which is highlighted: spiral models of software development, EPIS for implementation science, ICER for technology assessment, and UTOUT for user research. So here is a software development model, and it's here to show you how complex it is. So these guys are thinking that they're going through a spiral and doing a lot of testing and prototyping, and implementation is here. This little tiny thing is all software developers think about implementation, and they don't think much, it seems, about health technology assessment. Here is implementation model, and you can see a lot of factors that can influence implementation, but when you start looking for the other disciplines, they're not all that visible there. Here, what I found from user experience and the HTA and what's that? Software development, right? They just don't think about it. Health technology assessment framework, same thing. Really focusing on what they need to do. And this is user experience framework example. It shows that to predict user behavior, you need to access behavior intention and facilitating conditions and a whole bunch of other factors, and nothing from other disciplines. So when I saw all these frameworks, at first I thought, well, that's a problem. Everyone thinks differently because they have different theoretical models. And I thought about this example, right? It's an Indian fable about blind man coming to the elephant, and everyone is touching the elephant, and some people are touching legs and thinking they're columns, and some people are touching the nose and thinking it's a hose, and then someone is touching the tail, and they don't have bird's eye view of what is going on. But then I thought about this quote from Albert Einstein: we can't solve problems by using the same kind of thinking we used when we created them. I thought, whoa, that's a great opportunity, actually, right? We can, at the Reimagine HR, we have access to all these experts from different fields, and we just need to put them in one room, and then we'll discover something wonderful about evaluation, how to do it and scale it. But things are not that easy. So we found 9 experts from all these disciplines with 180 years of experience total. I was the youngest member of the team. But when we got together, we had this problem that we were using different frameworks and speaking different languages. For example, you know, the software developers were unhappy with term implementation. For them, it means you have an idea and then you implement it. That's implementation. But implementation scientists understand completely different thing. They think implementation science is when you increase adoption. And then software developers thought that design was just one of the things in that spiral, while user experience experts thought that actually development was part of the design. And I thought about situation in Europe because I'm from Russia. So in 19th century, there was one person who was thinking, well, how can we combine different languages so that people can understand each other, people from Poland and Italy and Russia and Germany and English. And he created a whole language called Esperanto, which is, I think, the first synthetic language, right? So maybe we can do something like that. Maybe we can create a synthetic language which includes words from all these disciplines. And there are also other approaches when people don't speak the same language, like, for example, force everyone to speak English or use Google Translate. And we couldn't really choose between these 3 approaches. And right, the question is, what can be our Rosetta Stone to bring everyone on the same page? And here's our first attempt. And I have to say that that meeting was on Monday. So we are, we are right in the middle of this. And our first idea was, well, let's think what questions people have and who they can ask. So we created a matrix where both in the rows and in the columns, you have the same 4 disciplines. And for example, software developers might want to ask user experience researchers what are the user tasks and workflows. And HTA researchers might want to ask implementers how to measure context variables, such as work environment. For example, I am health technology assessment researcher, and I don't know how to measure those variables, but it would be helpful to ask. And user experience researchers might want to ask health technology assessment researchers, that would be me, what providers used the app last month. And it actually did ask me that for the Billy app when we needed to assess usability. And they also asked it but when they want to go into the clinic and do the research, they need to know in advance from the electronic health record data which doctors they should talk to and what kind of patients they will see. So this is really a combination of user experience research and data analytics. So our third goal was to improve links between phases. And we think we can use this same question matrix across the project stages. And it took us a while to even figure out what framework to use for project stages, because software developers see project stages very differently. But then we can use the same questions, but during different phases, which will allow us to figure out what things we need to know in the exploration phase and on the preparation phase, and also who should ask whom these questions. Okay, so with the question matrix, we can solve the first 3 problems. And then the last one is how to scale up by reusing the pragmatic methods. And we made a list of methods which we are using. I hope they might be useful to you as well. So we are using methods in study design, data collection, and data analysis and reportings. And we also created some artifacts to speed up this reuse. So for study designs, we are using one original study design with scenario-based simulation, when we create patients in the test environment and then ask physicians to provide good care to these patients. And then we can assess, well, how good was the care. So that's a good scenario for efficiency or efficacy, because we can measure both how long it took them to assess these scenarios and whether they provided good care. And we published a paper doing this analysis for Disease Manager app. We sent surveys and we have some favorites, such as SUS, which I talked about for Billy app, or if you want to access how hard it is to do something, the cognitive load, you can use NASA TLX survey. We do custom surveys of patients, and to access efficiency, we do clinical trials. We try different designs, and obviously the best design we can do is cluster randomized trial. We can't really do real randomization because people talk, so you can't really randomize patients, or it's pretty hard to even randomize providers. So we're doing one study now with provider randomization, and we are doing another study with clinical randomization. But when it's not feasible to randomize, we do pre-post trials, interrupted time series trials, and step-batch designs. Another things which we are trying to standardize are methods for collecting data. Collecting our own data is very expensive, especially if it's clinical data. We don't have money to do that, but we collect behavior data. And we also use secondary data from EHRs and from app logs, but those data are often not created for secondary use, and the data quality is not very good, and the logs might keep changing, so it's hard to parse them and might miss important information. We also use literature, but for example, doing systematic review is pretty hard and expensive, and then systematic ones could be biased. And finally, our favorite option is to ask expert opinion, which we do all the time, but it's weak evidence. Here are the methods for data analysis. What I do is electronic phenotyping. When we get data about many patients, then we put them in the groups and make conclusions about those groups. Need to do statistical analysis, need to know how to do analysis of qualitative data, which are interviews, and data visualizations. And we try to use reporting standards such as FHIR and Consort. Finally, we created several reusable artifacts such as checklists and REDCap questionnaires. We have templates to write RBs faster. We have little pieces of code which we can combine to do evaluation faster. And we also use a common file organization so that different collaborators could actually find things because they're the same for each project. Here's an example of a reusable artifact, which is an exploration checklist, which we used before even said, okay, we'll work on this problem. We ask a lot of different questions about how hard the problem is. And important question to ask is whether there are alternatives. We need to go to Epic and ask them, hey, are you going to work on this? And if they're going to provide a solution in a year, right, it probably doesn't make sense to us to even start working on it. And if we didn't ask them, we would not have known. Okay, so for the second project, which is still ongoing, so far we have question matrix, which we are going to develop to have more questions. And we have a library of pragmatic approaches, which could be reused. There are a couple of more issues. The big problem is movement target problem. Everything keeps changing. The HR keeps changing. The apps itself keep changing. The context keep changing. And we are not currently keeping track of all of that. And there are not really good methods to keep track of all of that. So those methods need to be developed. And the second big problem is budgeting. Usually people budget 5 to 10% for evaluation, while to really do it, it takes 15 to 30%. And we are not sure what to do, because if we submit grants saying, hey, we are going to spend 30% of the grant on evaluation, we might never get those grants. We'll see. But another good approach to make it cheaper would be to use automation, right? I have some experience with that with electronic clinical quality measurement. What happens now often when I'm writing code to do evaluation, I have to write everything again from the first developers write it. And then I write it separately using SQL and R. And wouldn't it be nice if when developers wrote the code, they also thought about evaluation, and then the app itself could evaluate itself? It would be nice, but we are not there yet. Okay, so I talked today about 3 things. why and how we made an evaluation program. I gave you one example of evaluation of individual app, which we evaluated several right now. And then finally, I talked about developing a holistic evaluation model for HR-based interventions and how it's hard because people rely on different theoretical models. So the message I would like you to take home is that when you're starting your own project, you need to bring together experts from related disciplines and make sure that they can communicate effectively and also use pragmatic methods that could be reused from project to project. I would like to leave you with this quote from Simon van Warin, who is a futurist. Effectively, change is almost impossible without industry-wide collaboration, cooperation, and consent. And I would just like to call everyone to collaborate. Here's our team. This is 10 people who report to Ken. These are additional people on the team who don't. We have a great team of executive leadership who supports us and a lot of different clinicians who work on the projects. Don't forget your certification point. Thank you. And I think we have 15 minutes for questions.
Thanks, Polina. Thanks for sharing your work with us on evaluation. Does anyone have any questions? Either unmute or post them in the chat. We have a comment from Kathleen in the chat. She says, wonderful to see this level of systems thinking and evaluation.
Thank you. Thanks, Kathleen. And nice to meet you.
Maybe, can I follow up my comment? I'm just delighted to see this kind of thinking around evaluation. I so relate to many of the issues you flagged. And I think my question goes to the fact that you're working in a kind of closed system, in that you have university researchers and clinicians in a very tightly bound academic clinical system. Often we are invited in as evaluation advisors when the app is not so tightly bound to an in-house EHR or a particular commercial product, and that opens up the range of options and the number of stakeholders quite a bit. Have you thought about that in terms of how you go to expand your method and system?
Yeah, so the question is, while Reimagine HR is within an academic center and it's easy for us to access all these experts, and obviously we need to do less than, for example, a third-party app to evaluate, and we don't need to bring experts from outside to evaluate our app, so it is easier. We actually consider it our advantage that things are so close together. However, we have collaborators, for example, from industry who come to us. The medical calculator app, which we developed, actually is a collaboration with medical calculator website, and they come to us for evaluation. So here, it becomes less tight. So what do? We have meetings with them. They are very good with project management and telling us what they want. And then we, on our side, since we have resources in clinical care, we can organize trials. So it would be even harder if we came as third-party evaluators. And I think this is what health technology assessment field is all about. What do you do when you have no relationship to the people who made the app? And what you do, I think, is you get money from grants and evaluate the app across multiple healthcare systems, which would be much more expensive and still has to be done. Does it answer your question?
Right. We have a comment from Daniel. He says, great talk. 2 questions. How do you manage randomization inside Epic? And could you do A/B testing of app features?
Okay, so first, randomization within Epic. We manage it in different ways. Sometimes we do it through the app itself. For example, for those medical calculators, we are going to do randomization on the clinician level, and we are doing it through BPAs. So some people will get reminders where BPAs are randomized. And for that, you need to know the ID of every provider, and then you need to randomize them separately. And then you just put their IDs for half of the BPAs, right? So you create two BPAs. One can be silent and another one can be not silent, and they have different lists of provider IDs. And at the same time, we'll give the same provider's IDs to the website, right, our collaborators. And on their side, they will also show some content only to the half of people. So I don't think we are using features directly from Epic to do randomization, but we manage. And another way to do randomization is just the clinic randomization. And we don't do patient randomization because it's just technically very hard on people. You can't ask providers to, hey, do this for one patient, but not another. So when we do clinic randomization, we can do it just in Excel, right? You just use random numbers and then sort it by random numbers, and the first half of clinic is where the intervention is coming. Okay, so the second question was about A/B testing. We currently don't do A/B testing because we are such a small team. So that's something we are really interested in doing next, especially because we want to explore more implementation science approaches to increase adoption, right? That's something that could have some parallels with A/B testing. So yes, that's something we are planning to do, but we just need more resources to get to it.
Thanks, Polina. We have another question. How does your evaluation program link with or contribute to the regulatory frameworks in the US? For example, the FDA mHealth app certification program that certifies apps that are used for use medical device, software as medical device.
Well, currently it doesn't. We would like to contribute in the future, but we are not there yet, as we had our first meeting on Monday to even figure out what our next steps would be. And currently if you go to Epic Orchard, they don't have much information about evaluation. The only information they have is about reach. It would be really nice if FDA told them, hey, you have to show like all these 10 different things. You have to show whether users are satisfied. But currently, for example, in Epic Orchard, they don't have this information, and neither do they have this information for Smart and FHIR apps in other repositories. So even though there are some FDA regulations, I don't know how tightly FDA enforces them, probably not as tightly as for pharmaceuticals. And all those rating systems, I think, are also not as developed as for pharmaceuticals. And this is something we are going to explore and hopefully contribute to.
Yeah, thanks. Sounds like it's early days. Daniel has another question. So he says he might be wrong, but he remembers that there's a bilirubin FHIR app in the Smart app catalog. Have you decided on how to share or distribute your apps, and how can we prevent us from having multiple apps doing the same thing?
Okay, so I think the app he's talking about is Intermountain App, which is also from Utah, and they made this app using only basic interfaces, and the app ended up being not very useful. When we showed it to our clinicians, they said that, well, that doesn't mean their criteria. So we built, actually, we got the code from Intermountain, and we built on top of it to make it better, and that's our app now, and we are preparing it to put it in Health IT Gallery as well, but it's taken be there soon. And I don't think we need to prevent ourselves from having multiple apps. That's the whole idea of app economy, that eventually they will compete. And that's why we need evaluation too, right? So that people can know which app is better. And that's the whole idea. I would love to have 10 apps for bilirubin and people being able to use the best one.
Yeah. Okay. Next question from Frank. I gather you used a simulator EHR, is that correct?
No. So Epic has different environments. It has production environment where people work, and it also has a test environment where you can test new software. So we have access to this test environment, and that's where we did our simulated testing.
Yeah, thanks.
It actually has a lot of environments, not just those two. There are probably 5.
Yeah, I'm aware of that, and but we've found it difficult in health in Australia to get access to those environments for research purposes and testing and trialing.
That's true. It was very hard for us too. We just Ken is a great communicator, so he gained trust from the Epic folks, and now we have access.
Yeah, that's fantastic, because they just won't stand up another environment for you to do, you know, a simulated EHR for testing or training for education. It's just really hard to get a hold of in Australia.
Yeah, that's a great idea. Which one are you using? One?
Hospitals in Australia, yeah, there's a few with Epic. That's more recently, in the last 5 years or so. But majority of Australia would be probably on Cerner.
Mm-hmm.
And yeah, they just it costs them too much, I think, to maintain another instance for us. So yeah, we're trying to piggyback into test and education sort of instances, so that yeah, but you have to have a favourable hospital to be able to do that.
So are you using a simulated HR yourself?
Not at this stage. We're
Okay.
still working towards that.
Okay, I see. Yeah.
I did have another very quick question. You mentioned the system usability scale, which I'm a keen advocate of, but you've actually got objective with excellent, best imaginable, and yeah, I only understood that the score above 68 was either usable or not, and so I'd be very keen to get more information on that. I might connect with you on LinkedIn.
Yes, I would love to send you. So there is a paper where they kind of ran those scores, and then they matched. Oh, it's pretty long way to get there. So there's this paper where they match specific SUS scores to specific ratings, and we used that paper.
Great. Yeah, it's very handy to get a bit of an idea of how you're traveling, even through the development of a solution. And obviously at the evaluation stage.
Yeah, I was trying to get to the slide to see if I had the link to the paper there, but not making very good progress there.
I'll connect with you. Thank you very much. And thank you for the talk.
Thank you, guys. It's a pleasure to present here. And no link to the paper on the slide anyways. But yeah, so they gave ranges for this here on the side. It's like awful, okay, good, excellent, and best imaginable.
We have one more question on the chat, which is, what proportion of FHIR resources did you find that Epic had implemented and supported versus what was available more broadly?
Okay, so we have US core FHIR profiles in US, and that is what HRs are at least trying to implement with some variations. So I think US core FHIR profiles are represented pretty well, but that's a very limited set, which, for example, for Billy app completely didn't meet our needs. But for medical calculators, we only used US core profile. So we only used what was in Epic. If it was not available, we didn't develop additional interface. So I guess the answer is, well, fair amount. I don't know exact percentage. And it's growing every year. When we were developing Billy app in 2016, there were a lot of interfaces missing, so we had to develop them. But then even 2 years later, many of those interfaces actually were replaced by standard ones. So we were able to switch to them. And if you really want some interface, I think you can submit a request to the group who is making US core FHIR profiles, and then sooner or later they will add it US group FHIR profiles.
Thanks, Polina. Well, we are right on 1 o'clock. Thank you so much for taking the time this evening in Utah to speak with us here in Melbourne. I just want to mention that this is our last seminar in our lunchtime series for the year. And that although we have our Center for Digital Transformational Health launch in a few weeks on the 19th of November. So for those who are on our mailing list, you would have received an invitation to attend. Or for those who would like to be added to the list, please email us. And just want to thank you all again for joining in. It's been great to have all of you here, especially the regulars on Thursdays, participating in the post-presentation discussions. I hope that the seminar series has been informative and useful for all of you. And thanks again, Polina, for being our guest speaker today.
Thank you so much. Thank you so much for hosting me.
Yeah, have a great afternoon, everyone.
Thank you, Polina. Thank you, Dawn.
Thank you.